Good morning. My name is Stéphane Zuily. I'm a French cardiologist in training from Nancy University Hospital. On behalf of all European young cardiologists in training, I'm so happy to be here today to interview Peter Libby, head of the Department of Cardiovascular Medicine in Brigham and Women's Hospital in Boston. This interview is a part of the CardioStar project, and this project is very important in order to have a tremendous discussion between young and world-famous cardiologists, between mentor and mentee. And this is an initiative from the Cardiologist of Tomorrow group, which was created last year by the European Society of Cardiology for young cardiologists in training. So, Professor Libby, you know that it's a great honor to be here today, and it would be a dream if it was possible to pick a part of your brain today. So, if you don't mind, let's start with your background. So, Professor Libby, where did you grow up?
I grew up in California.
And what did your parents do for a living?
My father was a chemist, a pharmaceutical chemist, who at first did academic work at the University of California at San Francisco, and then became an entrepreneur and built up a small company for manufacturing topical pharmaceuticals. And my mother was a real estate agent and who eventually began to help my father in his business.
And did you grow up in a large family?
No, we were in the great California tradition, a blended family, where my mother had died during the polio epidemics in the early 1950s, and my stepmother had lost her husband just after the Second War. And so my parents remarried, but they each had 2 children from their previous marriage because they'd lost their spouses. And so we were a blended family of 4 children with the 2 parents.
Okay. And where did you graduate?
Well, you know, in the US, we do our university before starting our professional studies. So I had 4 years of university at the University of California at Berkeley. And that finished in a very interesting time, around 1969. And then I went to medical school at the University of California in San Diego, in La Jolla, which was a brand new medical school at that time. And I graduated from medical school in 1973.
Okay. And were you a good student at that time?
I was a late bloomer. I think that in my early years, I was a bit rebellious and perhaps did what interested me more assiduously and the topics that were not of interest to me. But I think I came into my own as I matured. So I wasn't a particularly good student.
And why did you choose medicine?
I chose medicine for a number of reasons. One, because there was a family tradition. My stepmother's father had been a physician, and he told some interesting stories which led me to understand that if you were a physician, that you had certain degrees of freedom which you might not have in other professions. For example, during the Second War, my stepmother developed rheumatoid arthritis and actually a pericarditis, and she was in a remote place on an Indian reservation volunteering in Arizona. And he wanted to drive, he was a physician, to see her. And at that time, gasoline was rationed because of the war effort. And he went before the rationing board and said that he would stop practicing if they didn't give him the certificates, the ration certificates for getting gasoline. And that story struck me as an important example of how in what you call the profession libérale, you may have more degrees of freedom than if you are a salaried employee. But of course there were other intangible reasons and perhaps altruistic reasons that I went into medicine. One is because I had a penchant for an interest in science. And when I was growing up, it was during the era of a great deal of technological innovation and push towards high technology with the conquest of space and with rapid development of a number of emerging technologies. In addition, biology was entering a very exciting time with the identification of the genetic material. And I thought that medicine was a perfect way to combine an interest in humanities and in helping people with the science that was taking off. And of course that turned out to be a good choice for me.
I share completely your opinion. And why cardiology later on?
I think cardiology was a very simple choice for several reasons. One is that there was a history of cardiovascular disease in my family, so part of it was counterphobic. In other words, to master the disease which had afflicted a number of my relatives. And I think the second thing was that on the first day of medical school, I met a person named Eugene Braunwald, who gave us our first introduction to the clinic. And of course, I was mesmerized by his personality and his accomplishments, and immediately attached myself to his team. And I'm still on it now, many years later.
And what were your dreams and your objectives when you studied medicine or cardiology?
You know, I think when you embark on a research career, in the back of your mind is an ambition that you might not even dare to say, which is you'd like to change medicine. And I think that that was my ambition, and I think that that is what we should all strive for in medical research.
You just said that Braunwald was someone very important for you, but do you have in mind a memorable experience in medicine, or a patient, a clinical situation, or someone who led you to your job?
I have to say that in clinical medicine, I remember my mistakes much more vividly than my successes. I can still remember the names and faces of patients who suffered complications under my care. They are seared into my memory, and it's very interesting how those situations stick with me much more than perhaps when you've made an unsuspected diagnosis or been able to put two and two together. So I've learned from patients, but learned, I hope, from my mistakes in medicine.
And no happy, memorable clinical situation?
I think we all have many situations which have been positive, where we think that we've helped people. But I have to say that beyond the technological part of medicine, I learned a tremendous amount about how to use your personality as a cure. From Bernard Lown, another one of my great teachers and mentors. Now, Dr. Lown and I may disagree quite a bit about therapeutics, but what I learned from Dr. Lown was the approach to the patient, how every gesture is so important, because what for you is a routine moment, for the patient is an absolutely pivotal moment. And we have the privilege as cardiologists of interacting with patients during a decisive moment of their lives, and their senses are finely attuned to our every gesture, every change in our voice. And so I learned a great deal from Dr. Lown about how to use my hands and my voice and personality to put people at ease and to try to help them through these difficult periods. So I think that being a good doctor requires both technological expertise and professional superiority, but of course that changes from year to year. The guidelines change, knowledge changes, our database evolves. So the technological aspects of medicine are fleeting, they're transient, they're ephemeral, but the approach to the patient, I think, is fundamental. And one of the things that I try to teach when I'm on the wards or when I'm in clinic with my fellows is the approach to the patient, which I learned from Bernard Lown.
Okay, and can you develop on all the mentors that inspired you at the beginning of your training?
Well, I've already mentioned some of
Yes.
my clinical mentors, and of course Dr. Braunwald, who's been a mentor scientifically, medically, and from a career perspective as well for the entire duration of my professional life. But I've had a number of other opportunities to interact with people who have taught me things. I did my postdoctoral fellowship with a biologist, Alfred Goldberg, at the Harvard Medical School, where I studied protein turnover and protease chemistry. And I have to say that Dr. Goldberg was a very severe taskmaster. He actually had dropped out of medical school with only a few months left to complete his MD degree. And he was particularly tough on MDs in his laboratory. And I have to say that my formation under his supervision really instilled a sense of rigor about science and chemistry, which I find in my worst days as a supervisor in the laboratory that I'm imitating.
I feel that you think that mentorship is very important between mentors and mentee. And do you think so? Do you think that it's very important to give all your knowledge to young generation?
Yes, and as I say, it's not just the knowledge, it's the approach to people, the approach to the problem. Now, you know, we have a great deal of vanity about our own scientific accomplishments, but if we really take serious stock, most of what any of us have produced in our scientific work is, as the technological achievements in medicine, something which will be proved wrong or which will be superseded rather rapidly. So the enduring satisfaction in our enterprise is really the people whose lives you've touched. The patients, we spoke about that, but also the mentees. So I take tremendous and enduring satisfaction in the people who I've been able to help through their careers. It might be as a research supervisor, or it might be in my role as the director of the fellowship program at the Brigham and Women's Hospital for training physician investigators, or it might be even in developing faculty. We have some 80 or 90 faculty members in the division that I'm privileged to lead, and I'm able to help some of them along the various steps of their career. And seeing the young people whose lives I've been able to influence succeed on their own, that really is an enormous satisfaction and something that may well outlive anything that I've done in my laboratory.
Do you think that training abroad is very important for your young cardiologists?
Well, I think you have to go where the opportunity is for you to accomplish your goals. So you need to have very clear goals. There was a time in Europe where Europe was building up medical science or rebuilding medical science. Of course, in a generation or two before mine, many US physicians were coming to Europe to be trained. And there was a time when Europe was rebuilding its science base that to do medical investigation, that people found the opportunity was greater in the United States. And I would say that that's shifting. I've been very fortunate to be the beneficiary of many European fellows who've come to train in our environment. And many of them have gone back and been very successful. And that very success means that it's less necessary for young Europeans to come to the United States or to other countries for training. So I think you really need to decide what's your goal, what do you need to learn, and where's the best place to learn that. And I think that just going to get a Been to America degree is no longer necessary for academic success in Europe. Now, I do believe that there is an enrichment for getting to know another culture, for getting a profound knowledge of other languages, and for experiencing diversity during your training. So if that's part of your plan, then that's a wonderful value. But as I say, that even for the Japanese fellows who used to have to come to America, the graduates of our programs have gone back and established really excellent world-class laboratories. So it's no longer, I think, a necessity to get that BTA, been to America degree.
Okay. Now, let's move on your career in biology and especially vascular biology. Why did you choose to move on to vascular biology?
Well, when I started out in cardiology research was based on the myocardium. It was the myocardium and this and that, and the myocyte reigned supreme. And the concept of the blood vessel was of a passive tube, which would perhaps constrict or dilate to help to regulate the circulation and influence preload and afterload that would affect the ventricle. And I was somehow dissatisfied by this focus on the myocardium because it seemed to me, as a young trainee, that in the majority of our patients who have myocardial disease, the heart muscle itself is the innocent bystander. Hypertension is a vascular disease. Atherosclerosis is a vascular disease. And if you subtract those two pathological insults to the myocardium, then cardiovascular disease might be, or myocardial disease might be, an orphan. So I was really quite curious to try to understand the blood vessel because I thought that that was the fundamental problem in our field. And there was also a tremendous opportunity because part of science is enabling technologies, and cell culture of vascular cells was becoming available, and it was a wide open field at the time that I entered it. And I also have to say, I told you already, I confided in you that maybe I was a bit of an unruly student when I was a boy. And I think that growing up in Berkeley, California, during the 1950s and 60s, and a bit of rebelliousness actually helped me in my scientific career because it gave me the courage to break the mold, to go countercurrent, to swim upstream. And that's what I did when I left Dr. Bromwald's lab to go venture into basic biology and ultimately into vascular biology, because it was contrarian at the time.
Okay. And what do you think is the most important thing that you have accomplished in your career? The most remarkable?
I already expressed that I think that we have to have a certain amount of modesty about our own accomplishments, because they should be superseded, because that is the nature of science and discovery. But I am satisfied that there have been a few things that we have put together in our thinking in the laboratory that seem to have moved the field forward. And I would consider our basic commitment to the idea that atherosclerosis is an inflammatory disease is sort of an overarching theme that unites a lot of the work that I've done. When I entered the field of atherosclerosis research, it was considered a lipid storage disease, and the artery wall was considered a responder to lipid stimuli, and the field was really focused. The cell biology of atherosclerosis was focused on smooth muscle cell proliferation. And I had always been interested in inflammation biology. I'd had an excellent grounding when I was a medical student at the University of California in San Diego in general pathology, and had inspiring teachers. And so it was very easy for me to make the leap to think, well, maybe there's more to this than lipid. And what is it that transduces lipids and altered biology of the artery wall? And we believe that inflammation is an important missing link, and that's what we've been pursuing for 30 years or so in the laboratory. Now, subsets of that, which have been really fun for us, are understanding transplantation-associated accelerated arteriosclerosis, which seemed to me a bookend, an extreme case of immune or inflammatory-driven vascular disease or arterial disease, and picking that apart was a lot of fun. Now, I'm not so well known for that, but I'm still working on that, and the model that we hypothesized way back in the 1980s of a delayed type hypersensitivity response to foreign antigens as a driver of the arteriosclerosis really has now entered the textbooks, and it's pretty well accepted. And we still are working on transplantation, although I'm not so well known for that. But I do believe it's been a wonderful laboratory for looking at a type of arterial disease which is clearly driven by inflammation and the immune response. And then we had a lot of fun working on the mechanisms of plaque disruption and thrombosis, and have really spent about 20 years picking apart the metabolism of collagen that lends strength to the plaque's fibrous cap and looking at the factors that link inflammation and inflammatory cells to regulation of the fibrous cap, and hence the propensity of a plaque to rupture and cause thrombosis. And that's been a lot of fun through the last 20 years or so.
When you see the results of the last studies with statins therapies, it's a great satisfaction, I'm sure. I would like to finish with some questions. If you had the chance to do something differently, what would you do?
Well, you know, I try not to look backwards. I'm a very optimistic and positive person and don't spend a lot of time with regrets. So I'm sure that there were many times when I could have taken different branches and might have done better or worse. But I really don't look backwards. I like to look forwards and to the next challenge. You know, Dr. Bromwell, my mentor, is considerably more advanced in years than I am, but his passion and his work ethic are an example for us all to keep striving for excellence and to do even better every day.
And the last question, what is the greatest advice you can give to young cardiologists who are now starting?
You know, I think that you have to have a very clear idea that you must enjoy what you're doing. It must make you passionate, and you have to get up in the morning being excited about work. So very often I'm confronted with people who are being careerist, particularly applicants for a fellowship who are very eager to be accepted, and they are playing the cards that they think show that they are on the right path to professional success. And I think that that careerist approach can very often lead to disappointment. And I think folks who really have the passion for going through all of the vicissitudes that success in a scientific and medical career demands, they will have made a choice to do something that they really can't stop doing because they're so interested in it, they're so passionate about it. So my most important advice is to choose something not because it's the right pathway that you see or it's going to lead to the best career by checking the boxes, but something which really gets you excited, can get you up in the morning wanting to go to work, and will be a source of continuing satisfaction through the years.
Thank you so much, Professor Libby, for this inspiring interview. And on behalf of all European cardiologists in training, thank you so much.